Hello, 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 doctors. How are you doing? How are you doing? How are you doing? Please let me know in the comment section whether you can hear me clearly, because that's something I want to make sure we clear right off the bat before we go. Can you hear me clearly? Can you please hear me? Can you hear me clearly? Please kindly confirm yes or no. And wherever you're joining us from, let me know. Can you hear me clearly? Can you hear me clearly? Is it clear? Is it clear? Is it clear? Let's jump in. If it's clear, no, so that we can jump in. Okay, Dr. Joanna De Cruz, beautiful, beautiful. Dr. Sabine. Okay, so I'm getting it. It's excellent. Yes, it's clear. Because today I really, really checked on sure I'm doing the right thing. So hear me clearly. Let me make sure everything is good. Okay, good. So now let's jump in. Let's jump in. Tonight, remember you have a class on emergency medicine. Tonight you have a class on emergency medicine, right? So let's get into it. And please, kindly click like, share, and subscribe to our YouTube channel as well. Okay, kindly click like, share our YouTube channel so that many doctors will get to know about it and we can all grow together. So today we are doing approach to chest pain, part 2. I don't know. Maybe we may have to do even a third part because we can't finish everything chest pain. We are looking at, emergency cases, right? That you can't miss. So today, that's what we are doing. Thank you very much for all the well wishes. Good, good, good. Dr. Ronnie Lankela says hello, hello, hello. Dr. Richard Sharma, awesome. Okay. So I think now you can even see your comments on the page as well. Okay. Okay. So let's jump in. So doctors, please, if you have a WhatsApp group, if you have a Facebook group, if you have a Telegram group, don't hesitate to share the good news of MedCognito with everyone so that we can all study and benefit a lot from it. Now, remember that now the classes we do, we're going to cover the concept, we're going to solve some questions on it, and then we're also going to do active recall. Okay, active recall, because that helps you to really, really get the concept right in your mind. And I'll be very glad that you share where you are learning from. So if you can send a picture to +1 306 891 5649 +1 306 891 5649. I really, really appreciate it because it warms my heart to know that people are listening from everywhere. We have someone joining us from India. Beautiful. Edmonton, India. It's great. So please. Okay, so let's get in right away. Because tonight you also have a class, so we need to finish so you can join the class. And I hope your week was good. Okay, so let's get in there. So we are looking at the 9 deadly non-traumatic causes of chest pain. And there are also other traumatic causes as well. So we are not just doing non-traumatic, we're also looking at traumatic causes of chest pain, and we are looking at it from the historical point of view. How to make a diagnosis, how to examine the patient, what are the unique exam features, and some of them we've realized that at times ECG is critical for diagnosis. Some of them too, ECG is not also critical for diagnosis, right? Then what are the chest X-ray findings? What are the additional tests we need to do? And what is the important information we need to know about these causes of chest pain, which can present in the emergency room? Last week we did part 1, so if you did not see it, let me know, please. If you did not see last week's class, let me know. Can you just type something in the comment section, and then I can check and maybe send you last week's class? If you did not attend last week's class and you've not reviewed last week's class, please let me know. I'm going to send it to you right away. Okay? Because before we get into today's class, I want to make sure that you were in last week's class. So if you were not able to join last week's class, let me know. I will share the link with you. Okay? Right away. Okay. So please let me know. Let me know those who are in the group. Okay, so it looks like some people did not get it. So I'm sharing the link in the comment section. Okay. I'm sharing the link in the comment section for those who could not attend last week's class. Just click on that link. star it somewhere, and then you can you can then review it. Okay. Dr. Ronnie Lankela says I should send it to him. Doc, I'm sending it to you right away. Okay. For last week. So doctors, this is what we love to do here. Okay. So I've shared it in the group in the comment section. You can see it. You can see it there. Good, good. So we are just building on what we did last week, and we are just going to get into, what we need to know. So last week we learned that we need to review acute coronary syndrome. We reviewed that. We have to learn dissection. We review that. We have to learn pulmonary embolism. We review that. We have to learn tension pneumothorax. We review that. It was left with 5 other topics: tamponade, mediastinitis or esophageal rupture, okay, and then um, myocarditis, then stress cardiomyopathy, that is Takotsubo cardiomyopathy, and then perforated peptic ulcer disease. So for today, we're going to pick the two which comes right after the tension pneumothorax, which is um, cardiac tamponade and mediastinitis. We're going to pick up on those two and review them again. Okay, we're going to pick up on those two and then review them. So Dr. Abiola says, Dr. Boni, please share. Okay, I've shared the link to last week's class. Okay, so please, if you're excited about it, let's go. If we can't cover the last thread next week, we will find another time to do it. We are here, we are going together. And if you even want more details about this, our main program is there for you, okay, to enjoy it as well. But let's get into it. So, pericardial tamponade. What should we know about pericardial tamponade? Pericardial tamponade, just think about it. This is the heart, right? And you have blood collecting around the heart, and it's forming some form of restriction for the heart. So let's start with some questions. And get going. So you have a 52-year-old woman with a recent viral illness, presents with chest pain that worsens when lying flat. Okay, she presents with chest pain which worsens when she's lying flat and improves when sitting forward. She's tachycardic and dyspneic. On examination, the jugular venous distension is noted. ECG shows low voltage QRS and electrical alternates. Was the most likely diagnosis? A, is it acute coronary syndrome? B, is it tension pneumothorax? C, pulmonary embolism? D, is it pericardial tamponade? E, is it aortic dissection? Doctors, please don't forget to share the link in your various groups, okay? So other doctors can join. Don't forget to share the link in your various groups so that other doctors can also join and benefit from this class as well. So what's the correct answer? For those in the MedCognito group as well, I'm going to send a link as well there, and then you can just. So I can see a lot of doctors going for D, pericardial tamponade. And so this is the classic pain, operating chest pain, which is relieved by sitting forward. JVPs and increased ECG shows electrical alternance and low voltage. When you see these combinations, please think about cardiac tamponade. Okay, so where's acute coronary syndrome the wrong answer? With acute coronary syndrome, the pain is usually pressure-like and it worsens with exertion, right? Acute coronary syndrome. What about tension pneumothorax? In tension pneumothorax, you would have unilateral absent breath sounds and tracheal deviation. This last week, right? And what about pulmonary embolism? In pulmonary embolism, you realize that the patient will have dyspnea, shortness of tachycardia, but there's no, it's not position, and the JVP is not an increase, right? And what about aortic dissection? Usually, you realize that a patient with aortic dissection will present with um searing pain, okay, searing pain in the chest. and there is no electrical alternate. So that is it with pericardial tamponade, how the patient will present, what are the things you need to pick up. And when we are done with this, I'll make sure that I also go back, review it very well, in with the rapid review as well. Okay. So now, next question. Which of the following findings is most specific for pericardial tamponade? Which of the following exam findings is most specific for pericardial tamponade? A. Paradoxus. B. Pericardial friction rub. C. Bradycardia. D. Unilateral diminished right sounds. And E. Cyanosis on the lips. Which of the following exam findings is most specific for pericardial tamponade? Which of the following exam findings is most specific for pericardial tamponade? A. Pulsus paradoxus. B. Pericardial friction rub. C. Bradycardia. D. Unilateral diminished breath sounds. And E. Cyanosis of the lips. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? So I see that there's a battle between A and B. Some are going for A. Dr. Rehab El-Haj went for A. And then Dr. Theodora Brown went for B. Dr. Elvis Zolo went for B. Pericardial friction rub and pulsus paradoxus, which of them is most specific for pericardial tamponade? Pericardial tamponade. The correct answer is A. The correct answer is pulsus paradoxus. Pulsus paradoxus. Why? In pulsus paradoxus, you realize that there is more than 10 millimeters of mercury drop in the systolic blood pressure with inspiration. So when the patient breathes in, there is more than 10 millimeter of mercury drop in the systolic blood pressure. And when you see pulsus paradoxus, patient with chest pain, start thinking about cardiac tamponade. Please, doctors, start thinking about cardiac tamponade. Okay. Now, the pericardial friction rub. So please, I need you to write this in your book. Write this in the book you're using to take your notes. Pericardial friction rub is seen in patients with pericarditis. Okay, it suggests pericarditis more. What about bradycardia? Bradycardia is not typical. In patients with cardiac tamponade, usually they will have tachycardia, not bradycardia. And what about diminished breath sound? Diminished breath sounds more of pneumothorax, more of pneumothorax, and cyanosis is not specific, is non-specific. So, doctors, please note these very well. Pericarditis in a board exam, think more about pericardial friction rub. If you see pulsus paradoxus, maybe if I'm setting the patient, I'll not say pulsus paradoxus, I'll just say there's a 20 millimeter of mercury drop in systolic blood pressure when the patient breathes in. The well-trained medical exam taker will think that this is pulsus paradoxus, and because of that, I will need to start thinking about cardiac. Okay. Next one. A patient in shock is thought to have enlarged cardiac silhouette on chest X-ray. Enlarged cardiac silhouette on chest X-ray. Bedside ultrasound shows pericardial effusion with right atrial collapse during diastole. What's the most appropriate next step? What's the most appropriate next step? A. Administer furosemide. B. Perform emergent pericardiocentesis. C. Start heparin infusion. D. Order cardiac MRI. And E. Begin IV corticosteroids. What's the correct answer? What's the correct answer? So, in other words, this question is basically, if I have to put it again, what will you do for a patient with cardiac? A. I'm going to administer furosemide. B. Are you going to perform emergent pericardiocentesis? C. Are you going to start the patient on heparin infusion? D. Are you going to order MRI? E. Are you going to begin IV steroid? What will you do? And I see everybody's going for B, and the correct answer is B. Perform emergent pericardiocentesis. Okay, so this is a classic cardiac tamponade with obstructive shock. So that's another thing I want you to know in your book. And please send me a picture of the note you are taking. In your book, know that pericardial effusion or cardiac tamponade, the kind of shock cardiac tamponade will lead is obstructive shock. It's obstructive shock. If the patient is bleeding, that would be hypovolemic shock. If the patient has an infection, right, who can type the type of shock that patient will have? If you have a patient with an overwhelming infection like sepsis, what kind of shock would they have? What kind of shock will a patient with sepsis develop? What kind of shock will a patient with good? So Dr. Zedi's diary says the patient will have septic shock. So septic shock goes with infection, right? Bleeding goes with hypovolemic shock, and a patient with cardiac tamponade will have obstructive shock. So in a patient with cardiac tamponade, pericardiocentesis is the definitive life-saving treatment you want. The definitive life-saving treatment you want to give is pericardiocentesis. What about if you give furosemide? Furosemide will make the patient's condition worse. Furosemide will make the patient's condition worse. So Dr. Lankela clarifies the kind of shock a septic patient will get. It's more of distributive, right? Shock. So now, furosemide will make a patient with cardiac tamponade the condition worse. Heparin is dangerous without evidence of pulmonary embolism. So if the patient doesn't have any evidence of pulmonary embolism and you're just throwing heparin, that's dangerous. And then MRI is not appropriate in unstable patients because if the patient is unstable, why give MRI? Why do MRI, right? Oh, you guys are saying my voice is fluctuating. Hmm. Okay, let me check. Let me check. Okay, please. Can you hear me now? Just confirm yes or no. Doctors? Is it better? I'm just speaking. Is it better? Just let me know. Is it better? Is it better? Is it better? I want to confirm. Is it better? Is it better? Is it better? Is it better? Let's confirm. Okay, good. Good. Doctors, just I'm just saying better, better, better. Is it better? I want to know before. Okay, good, good, good. So somebody's asking, Dr. Brony, why furosemide worsen the tamponade? Because it decreases the preload. But don't forget, furosemide will cause you to lose more fluid, right? This patient is already in shock. This patient is in obstructive shock, right? If you are giving furosemide, it's going to decrease the preload and it's going to make the shock worse. Okay, okay. So next question. Next question. Which of the following ECG findings is most suggestive of pericardial tamponade with effusion? Which of the following ECG findings is most suggestive of pericardial tamponade with effusion? A. ST elevation in leads 2, P3, and AVF. B. PR segment depression with diffuse ST elevation. C. Electrical resonance with low voltage QRS. D. Peaked T waves. And E. Right bundle branch block. What's the correct answer? Let me know. What's the correct answer? Let me know. Is it A? Is it B? Is it C? Is it D? Or is it E? And looks like our correct answer is C, electrical alternates, right? So there's alternating QRS amplitude and low voltage, which are a hallmark of ECG signs of large pericardial effusion. Now, ST segment elevation in lead 2 and lead 3 and lead ABF suggests inferior myocardial infarction. So please, this is another assignment I want to give you. Know the various types of myocardial infarction and know the kind of changes you will see on ECG. So I want to give you an assignment. Please send me a WhatsApp on +1 3068915649. +1 3068915649. Now, what I need you to do in that is each of the various types of myocardial inferior, um, anterior, anteroseptal, right? Tell me which leads are affected. We're already learning that in inferior MI, the effect will be in lead 2, lead 3, and lead AVF. Okay. Now, what about PR depression and ST elevation? It is seen in patients with acute pericarditis, not cardiac tamponade alone. And what about peak T waves? Peak T waves will be seen in patients with hyperkalemia. Now, so this question stem also tells you that these are things you need to master, right? What are ECG findings in pericarditis? What are ECG findings in myocardial infarction? The various kinds of myocardial infarctions. What are the kinds of ECG findings you see there? What is the ECG finding in hyperkalemia? And I'll even add what is the ECG finding you must know in a patient with hypokalemia, right? You must know these things. So please send me a WhatsApp with that assignment, and I'll give you my feedback. So now, doctors, if you are pumped that we were able to finish those questions, let me know. Let me know because we're about to do a deep dive. We're about to do a deep dive. We're about to do a deep dive into pericardial tamponade. Deep dive into pericardial tamponade. Okay, pericardial tamponade. So let's go. Let's go. Let's go. Now, pericardial tamponade, as we've learned, is when fluid builds up around the pericardium. So just look at it. Fluid builds up, right? And what happens is that it squeezes the heart. It squeezes the heart. And when it is squeezing the heart, it is preventing the heart from beating properly, or from pumping properly, right? Now, pericardial tamponade will lead to obstructive shock. It will lead to obstructive shock. So that's also something you want to master for your board exam, whether you are taking the AMC, Step 2 CK, MCQA1. This is something you need to know. Even for our nursing students who are in NCLEX, you need to know the kind of shock which comes with pericardial tamponade. Now, how will a patient with pericardial tamponade present historically? Okay, look for board exam. Look for that person who has anterior chest pain. Now, the beautiful thing about pericardial tamponade is that the chest pain is worse with lying down or inhalation. So please, I need you to write this as well down. The chest pain is worse with lying down or inhalation. The chest pain improves with sitting forward. So if the patient sits forward, the chest pain in pericardial tamponade will improve. And you realize that in pericardial tamponade, dyspnea is common. Dyspnea is common. That is shortness of breath is common, right? Shortness of breath is common. So please write this down because this will help you to really, really master this topic very, very well. Write it down. Write it down. Let me give you time to write it down. Okay, so now that I've given you time to write these down, let's move on to the next one. Now, how are you going to remember the features of pericardial tamponade in your board? Write the words. So we talked about sitting, leaning forward or leaning backward. Leaning forward helps the pain. Leaning backwards makes it worse. So remember the word sit, SI pericardial tamponade, it causes sharp pain. So the S is sharp. S stands for sharp. Sharp pain. And then I is inhalation. So it is worse with inhalation, or it is worse when the patient is in bed. So when the patient lies down, it is worse. And then the next T is for tilting. So it is better when the patient tilts forward. When the patient tilts forward, the pain of pericardial tamponade improves. Doctors, is this a good memory guide? I want to know. Is this a good memory guide for you, where we are looking at how a patient with pericardial tamponade presents? Sharp pain, remember SIT, S-I-T, sharp pain, worse with inhalation, right? Or if the patient is in bed, and it is better when the patient tilts forward. Sit, S-I-T. Let me know in the comment section. Does it help? S-I-T. And if yes, please write S-I-T in the comment section. Write it down. Write it down in the comment section right now so that I know that you are following. S-I-T, S-I-T. Sit, sit. So sharp pain, okay? Sharp pain, worse when inhaling or in bed, and better when tilting forward. Sit, sit, sit. Now, what are the examination findings of a patient with pericardial tamponade? Examination findings. You realize that there is jugular venous distension. Jugular venous distension. Jugular venous distension. So if you do the JVP, it's elevated. And the pulsus paradoxus, you realize that this patient's blood pressure will drop significantly if the patient is inhaling, right? BP will drop significantly during inhalation. And then what about the friction rub? The friction rub may be heard, but that is not part of the harmonic of pericardial, right? That is usually in the early stages. Now, what are the signs of obstructive shock you need to pick up? Realize that obstructive shock will present with hypotension, tachycardia, and the extremities will be cold. Hypotension, tachycardia, cold extremities. So if you have this plus a patient who has increased JVP, you know that there's something wrong. Because in hypovolemic shock, the patient will be hypotensive as well. The patient will be tachycardic. The patient will have cool extremities. But in hypovolemic shock, the JVP will be low, and there will not be pulsus paradoxus. So the signs of obstructive shock that we have down there, hypotension, tachycardia, cool extremities, you will see it in patients with hypovolemic shock as well. But in hypovolemic shock, they will not have raised JVP. Rather, their JVP will be very low. So that's something you want to pay attention to. What about ECG? In a patient with pericardial tamponade, you realize that you have low voltage QRS complexes and electrical alternance. Let me take it again. Electrical alternance, electrical alternance, electrical alternance, and low voltage QRS complexes. And you will also see something like diffuse ST elevation and PR segment depression. You may see that the patient has pericarditis associated with it. But the typical ECG finding I want you to know and to put in your head is low voltage QRS and electrical alternance. Low voltage QRS and electrical alternance. I want you to keep that in mind. Okay? So this is what I want to bring to your attention. Okay? So electrical alternance. You realize that at times one is tall, is short, one is tall, one is short, one is tall, one is short, one is tall. So it's like alternating, right? The ECG, the QRS complexes, they are alternating. One is short, tall, one is short, one is tall, one is short, one is electrical. You even see that more. You even see that more here, even here as well. So let's move on. What about chest X-ray? Chest X-ray findings of a patient with pericardial tamponade. you realize that their cardiac silhouette is enlarged. Silhouette is enlarged. So if you look here, if you look at where my mouse is going, their cardiac silhouette is enlarged, right? Their cardiac silhouette is enlarged. Patient with pericardial tamponade. Okay. What about any additional tests you need to do? What about any additional tests you need to do? You can do your quick bedside ultrasound, which confirms diagnosis, and it will show pericardial effusion, right? So this is showing the fluid around the heart. And it may also show a diastolic collapse of the right heart chambers. Please write this down as well. Diastolic collapse of the right heart chambers. Diastolic collapse of the right heart chambers. And this is usually for tamponade signs, right? Diastolic collapse, pericardial effusion, diastolic collapse. So, the critical thing you need to know about pericardial tamponade or cardiac tamponade is it leads to obstructive shock. And I've talked about the features of obstructive shock. The patient has tachycardia, hypotension, full extremities, but if you check the JVP is elevated, right? So it leads to obstructive shock. And even though the heart is working, it can't fill or pump effectively because of that pressure which is around the heart. Therefore, what do? You have to stick a needle. That's why you see that. That is the pericardiocentesis, right? You have to stick a needle into the pericardial space and draw the fluid away so that the heart can have time and the space to expand. That's what you have to do. Okay? You have to put the needle, and that's what you call pericardiocentesis. It's emergency. That's why I was saying that this topic is dealing with the things which can kill a patient. So, doctors, I have a question. Has it been helpful so far? Has it been helpful so far? I want to know. Has the class been helpful so far? If it's been helpful, let me know in the comment section. Has it been helpful so far? Yes or no? Has it been helpful so far? Has the class been helpful to you so far? Yes or no? And are you able to now? Okay, this is why this is happening. This is why this is happening. This is why this is happening. This is why this is happening, right? Yes or no? Good, 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 good. So, quick board exam trick. How are you going to remember cardiac tamponade? How are you going to do that? How are you going to do that? The patient will have chest pain, plus the chest pain will improve when the patient sits up and leans forward. The neck veins will be bulging. The neck veins will be bulging. And then the heart sounds are faint. So this is the classic presentation. Let me go off the screen so that you can see it. Doctors, is this clear now? Is this clear now? Is this clear now? Good. So this is the chest pain will improve with sitting up. There's neck veins which are bulging, heart sounds are faint. Think about cardiac tamponade. Think about cardiac tamponade. Okay. So, doctors, we are going to the next topic. So, I have a question. If I ask you to tell me all the features of pericardial cardiac tamponade, investigations you can do, how you can pick it up, and then manage it, I hope you can do that. Doctors, please, I hope you can do that. Ask a question and I need an answer in the comment section. I hope you can do that. If I need to, how would the patient present? What kind of chest pain would they have? The chest pain they have, will it include sitting up or lying down? Which, what are the ECG findings? How will you manage the patient? Good, 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 good. I love to see this. I love to see this. Dr. Cello, Dr. Ikehuna Cosmas, Dr. Zolo. Awesome, 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 awesome. Sit. So now you know sit, what sit is all about. Okay, so now let's go to esophageal rupture. Let's go to esophageal rupture. Next question. 50-year-old man presents with severe chest pain after multiple episodes of forceful vomiting. His fever appears toxic. On auscultation, a crunching sound is heard over the chest with each heartbeat. Chest X-ray reveals pneumomediastinum and left-sided pleural effusion was the most likely diagnosis. A. Acute pericarditis. B. Aortic dissection. C. Esophageal rupture. D. Tension pneumothorax. E. Acute coronary syndrome. What's the correct answer? Is it A? Is it B? Is it C? Or is it D? And the correct answer is C, esophageal rupture or mediastinitis. So this is what we call, this is the classic Bohab syndrome presentation, right? Patient will present with chest pain after vomiting. The patient looks toxic. The patient has what we call the Hayman's sign. And I'll come to the Hayman's sign and what it stands for. And the patient has radiographic pneumomediastinum. These all point to mediastinitis due to esophageal perfusion. So think about it. The esophagus runs through the mediastinum, right? So if it opens up, if there's a tear in the esophagus, the contents of the esophagus then goes into the mediastinum. That's why the patient looks toxic. The patient looks very sick. This is a critical emergency, and it has a high mortality rate, right? It has a high mortality rate. So you want to watch out for that. Now, next question. Which of the following chest radiograph findings would most support the diagnosis of mediastinitis due to esophageal rupture? Which of the following chest radiograph findings would most support the diagnosis of mediastinitis due to esophageal rupture? A. Cardiomegaly. B. Mediastinum, pneumocystinum and pleural. C. Alveolar infiltrates. D. Normal chest X-ray. And E. Bronchograms with lobar consolidation. Which of the following chest radiograph findings would most support the diagnosis of mediastinitis due to esophageal? Cardiomegaly. B. Pneumomediastinum and pleural effusion. C. Alveolar infiltrates. D. Normal chest X-ray. E. Air bronchograms with lobar consolidation. Air bronchograms with lobar consolidation. Good. So everyone is going for B, pneumomediastinum and pleural effusion. So the classic, this one is also focusing on the classic chest X-ray findings. Right? It includes pneumomediastinum, pleural effusion, or pneumothorax. Okay. Now, the megaphone is seen in cardiac tamponade, not esophageal rupture. And diffuse infiltrate is seen in acute respiratory distress syndrome or pneumonia, right? And then normal in patients with mediastinitis, you will see abnormalities. And air bronchograms are seen in patients with pneumonia. Pneumonia. Okay? Now, so next question, which of the following is a common cause of esophageal rupture leading to mediastinitis? So the following is a common cause of esophageal rupture leading to mediastinitis. A. Hypertension. B. Dental infection. C. Recent travel. D. Alcohol use disorder with vomiting. And E. Chronic asthma. So the following is a common cause of esophageal rupture leading to mediastinitis. A. Hypertension. B. Dental infection. C. Recent travel. D. Alcohol use disorder with vomiting. And E. Chronic asthma. So I see a lot of doctors going for D, and D is the correct answer. So forceful vomiting from patients who use alcohol is spontaneous esophageal rupture or Bohab syndrome. Okay. Now, hypertension is associated with aortic dissection, and dental infection can lead to mediastinitis but not esophageal rupture. So remember that we are talking about mediastinitis. There are things that can cause direct mediastinitis, like dental abscess, right? However, you know, mediastinitis as a result of esophageal rupture, and that is what we are focusing on. And you realize that travel is not related, and asthma can cause barotrauma, but not. Okay, so now let's do a deep dive into mediastinitis. Mediastinitis. So mediastinitis can occur when there is esophageal rupture. Okay, and this leads to life-threatening infection of the central. So just can you imagine what goes through the esophagus? Food, some secretions as well. And now just imagine that the esophagus is torn and the contents of the esophagus have seeped into the mediastinum. My goodness, this patient will be very sick. The patient will be spiking the fever because there's obviously an infection going to go on. And there's spilling of air and fluids into the chest. And that is why the patient is looking that bad. Now, what are the historical features? How the patient with mediastinitis present? Usually, you in your board exam, you will hear a history of forceful vomiting. So the patient was vomiting forcefully. And then you will see that in the patient who probably has taken alcohol or something, right? But then there are other things you need to watch out for. There can be recent upper endoscopy. So if you have a patient with recent upper endoscopy, chest pain, fever, it should cause you to start thinking in a board exam. This could be due to mediastinitis. This could be due to mediastinitis. I can't miss this. Recent upper endoscopy, esophageal instrumentation. Another thing, patient with then tooth pain, and then now you're being told the patient has fever and chest pain. Trouble. So another thing is, it presents with combined chest and abdominal complaints as well. And they may describe sudden chest pain after vomiting or a procedure. These are the things we should be drawing attention to. This is mediastinitis. So I'm dropping another acronym which helps you remember mediastinitis very well. Remember, we talked about SIT when we're dealing with which condition, please? Who can remind me? Which condition goes with SIT? I want to know. Which condition goes with SIT? Who can remind me? Which condition goes with SIT? Which condition goes with SIT? Which condition goes with SIT? SIT. 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 Which condition goes with SIT? Because we are going to learn another acronym. But I want to know which condition did we learn that goes with SIT? SIT. Cardiac tamponade. Beautiful. Cardiac tamponade. Cardiac. So now, let's learn another acronym. Vomit. Vomit. Because remember that we said mediastinitis, esophageal rupture. It goes with vomiting. So vomit. So these are the classic historic features, right? So you will see a patient who vomited, or you will see a patient who has odontogenic infection, like that is tooth infection. And then the patient will present with mediastinal pain. The patient will also tell you that the patient had instrumentation. And then you also told that the patient is toxic looking. So vomit, right? Vomit, VOMIT, vomit goes to how to remember the causes of mediastinitis. It can be due to esophageal rupture. It can be due to tooth infection. It can be even due to instrumentation of the esophagus. Okay, let's continue. Now, what are the examination findings of a patient with mediastinitis? The patient is ill appearing, the patient is febrile, and the patient is possibly in shock. So I want to ask you a question now. What kind of shock will the patient with mediastinitis present? We learned that the cardiac tamponade will present with obstructive shock. But with mediastinitis, looking at the patient has developed fever, there's an infection going. Is it going to be hypovolemic? Is it going to be obstructive? Is it going to be neurogenic? Is it going to be what kind of shock? Tell me, what kind of shock will a patient with mediastinitis present with if they go into shock? Okay, so he says septic shock. That's what Dr. Elvis Zolo is saying. Septic shock. Or what kind of shock? Distributive shock. Right? It could be septic shock or distributive shock. So the human sign that I mentioned, the patient with mediastinitis, they will present with crunching sound over the chest. So if you're told that the patient has crunching sound over the chest and it is synchronous with heartbeat, right? Crunching sound over the chest and it is synchronous with heartbeat. Start thinking about mediastinitis. And the Hayman sign, that crunching sound, is caused by air in the mediastinum. So the human mediastinum is what leads to the Hayman's sign. The Hayman's sign. The Hayman's sign. Now, we will do our ECG, but in mediastinitis, will ECG show us anything specific? No, it is not a diagnostic tool in mediastinitis. ECG is not a diagnostic tool in mediastinitis, right? ECG is not a diagnostic tool in mediastinitis. What about chest X-ray? What about chest X-ray? I have a question. Who can remind me of the chest X-ray findings in cardiac tamponade? Chest X-ray findings in cardiac tamponade. Who can remind me? I want to find out. Who can remind me? Chest X-ray findings of cardiac tamponade before we go to mediastinitis. Chest X-ray findings of cardiac tamponade. I want to know. Chest X-ray findings of cardiac tamponade. Cardiac tamponade. Chest X-ray findings of cardiac tamponade. Then we will learn the chest X-ray findings in mediastinitis. Good. So enlarged cardiac silhouette, right? Large cardiac silhouette. That's what somebody is saying there. Large cardiac silhouette. So what about the X-ray findings in mediastinitis? You realize that there's pneumomediastinum, there's pleural effusion, and there can be pneumothorax. So write these ones down as well. Pneumothorax, pneumomediastinum, and pleural effusion. So an additional important information is that this patient will have high mortality, it's a surgical emergency, and early recognition from the history, where we are told the patient vomited, had sudden chest pain, developing fever, it causes you to think. And if it's distributed and the patient has fever, then you know that part of the management is that you're going to give your fluids, you're going to give your antibiotics, you're going to call the surgeon, the cardiothoracic surgeon, right away that, hey, we have an emergency on our hands. Okay? So, mediastinitis made simple. Think about this. Patient looks septic, very sick with fever, and this happened after vomiting or an endoscopy. That should cause you to think about preparation or mediastinitis. Okay, doctors, please, how was everything? Now we're about to go into our active recall. As I said, the chest pain concerns, they are very unique, and I want to make sure that build it up gradually and take everything step by step. So I don't want to overwhelm you. I think with today, with all the ECG findings, chest X-ray findings, the various outputs and everything. So we're about to go into the active asking. I hope the class has been helpful so far. The class has been helpful so far. Awesome. Now, just to remind you that we still are running our QE1 program, right? Tonight you have emergency medicine, and we know that there are various options. You can just decide to come into the program for just 1 month. That's just 450. But if you want to go for 2 months, 3 months, 4 months, you can use our recurring payment plan of just $420. Okay. And if you want to also get 6 months access right from the word go with a one-time payment, you are going to save about $350. And so with just $2,200, you get 6 months access right from the word go. So doctors, I'm just making you know about that. So you can join us as well. If you are preparing for your TDM exam, TDM will start on July 16th. And if you're preparing for NACOSKI as well, NACOSKI has already started. And you can jump on the NACOSKI course as well. Okay, so now that I've talked about all this, let's jump in and let's do active recall. Active recall. Now, what type of chest pain is typical in pericardial tamponade? What kind of chest pain is typical in pericardial tamponade? I'm going to just give you 10 seconds. What kind of chest pain is typical in pericardial tamponade? I'm going to use my counting clock. What kind of chest pain is seen in pericardial tamponade? Okay, so I've seen what sharp anterior chest pain, sharp anterior chest pain, which is worse with um sorry, I'm just trying to set my phone so that we can do the countdown, 10 seconds countdown whenever I bring a question. So sharp anterior chest pain, worse with inspiration or lying down, and it is relieved by sitting forward. Okay, that's the first. Next question. What are the two key physical exam findings in cardiac tamponade? 10 seconds. What are the two key physical exam findings in cardiac tamponade? 10 seconds starts now. Please type in your answer. Two key physical exam findings. Okay, maybe let me increase it to 15 seconds because it looks like 10 seconds is too short. I'll make it 20 seconds. 10 seconds is too short. Two key physical exam findings. Okay, so I see pulsus paradoxus there. So you have jugular extension and pulsus paradoxus. And pulsus paradoxus is more than 10 millimeters of mercury drop in systolic during inspiration. Beautiful. Okay, next question. I'm really enjoying the active recall. Next question. Which bedside test confirms the diagnosis of tamponade? Which bedside test confirms the diagnosis of tamponade? 50 seconds pass now. 10 seconds more. Which bedside test confirms the diagnosis of tamponade? Okay. 20 seconds is up. The answer is ultrasound or echocardiogram, right? It shows pericardial effusion with the right chamber collapse. Ultrasound or echocardiogram. Okay. Next question. Good. Looks like everybody is getting it right. Good. What ECG findings are most suggestive of cardiac tamponade? What ECG findings are most suggestive of cardiac tamponade? Your 20 seconds starts now. Time is running 17 seconds. 12. 5, 3, 2, 1. Time up. Okay. So we're looking at the ECG findings. Good. Dr. Joanna the Cruz. Good, 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 good. So the ECG findings are electrical alternates, electrical alternates, low voltage QRS complexes, electrical alternates, and low voltage QRS complexes. Next question. What is the most common precipitating event in spontaneous esophageal rupture? What is the most common precipitating event in spontaneous esophageal rupture? 20 seconds starts now. 16 seconds. 9 seconds. 8, 7, 6, 5, 4, 3, 2, 1. There we go. Okay. So what's the correct answer? Forceful vomiting. Good. Forceful vomiting. Forceful vomiting. Next question. What recent medical procedure significantly increases the risk of esophageal perforation? What recent medical procedure significantly increases the risk of esophageal perforation? Your 20 seconds starts now. 5 seconds more. Time up. So the correct answer is upper GI endoscopy or instrumentation. I'm very happy. People are really participating in the class. That's awesome. Okay, next question. What are typical chest X-ray findings in mediastinitis? What are typical chest X-ray findings in mediastinitis? What are typical chest X-ray findings in mediastinitis? Your 20 seconds starts now. Typical chest X-ray findings in mediastinitis. 3 seconds more. There we go. So typical chest X-ray findings in mediastinitis. The correct answer is what? Pneumomediastinum, pleural effusion, or pneumothorax. Pneumomediastinum, pleural effusion, or pneumothorax. Okay. So doctors, thank you very much. That was a very good class. How was the class? Does somebody want to join me live and share what you've been picking up in the class? Want to join me live and share what you've been picking up? Let me know. I can. Uh, yeah, if you want to join me live, I can just take sharing what you've learned in the class so far, not just this class, but all the like. If you're a medical student, Dr. Zeddy says nice phone. If you want to join me, you can let me know. I can just I'm sharing the link. So if you want to join me, just to share what you've been learning in the MedCognito class, let me know. Okay. And this one, if you're going for QE1, if you're going for A, if you're going for lab, whatever it is that you're going to do, you can use this information to help you. Okay? And doctors, don't forget tonight there's a class. If you want to talk to me, just send me a WhatsApp right now, because usually after class I get so many um calls. So if you want to talk just send me a message after this class. I'm going to talk to you right away. You can join the class for just $420 a month for 6 months, a one-time payment of $2,200, right? So someone is asking this question: what's the difference between cardiac tamponade and acute pericarditis based on symptoms? Okay, I think Dr. Ricky has joined us. Dr. Ricky, I want to hear you. What do you want
How are
to
you,
say?
sir? How are you?
Let me-
Are you able to hear me properly? I am audible? Just a minute. Are you able to hear me?
Yes, I can hear you. Can you hear me?
Thank you so much for your time, and I really appreciate the pattern and the way you teach. So the only thing was I just wanted to know. I've tried once MCCQE exam, and I was just missed it with few marks, and because I think I'm an old international medical graduate, and there are some points which needs when you are in practice, you are not able to gather that point sometimes. So I would just be happy if you can just help me out to somehow get over it. And yeah.
Get over which one specifically?
There's a graph which is always there after the examination, what
Sure.
you missed. And
Yeah.
so I tried to evaluate that, and
Sure.
in the end I could make out that there was something missing, like links in treatment protocols,
Sure.
current treatment protocols, and so forth, as far as planning and management of emergency cases. So that was not a big deal.
Sure.
But that pattern of approach, because it's more inclined towards family medicine, right?
Yes.
And once you've worked in, scenarios like emergency and critical, it's slightly difficult to get back to the basics of, like a graduate level,
Mm-hmm.
the thinking of and the dimension of thinking towards that. So I
Yes.
think that is the missing link. And yeah.
Okay. So, Doc, I'll be very glad to have a private chat with you. And then you
Yeah.
can even send me your supplementary results. I'll analyze it and then we can review it together. Is that okay?
Yeah, that would be
Good.
fantastic.
Yeah.
What is
Yeah.
your WhatsApp number? I would just like to
My
note it.
WhatsApp number is +1 306 891 5649. Okay, because there's something I need to talk to you privately about, so that I can really look at how your marks were distributed and everything, and then advise on it. Okay.
For sure, for sure. I will like you to just either write it down in the private chat if you don't mind your number.
Okay, sure. I'm
Yeah,
sending it to you right away.
yeah.
So +1, and anyone who wants to talk to me, please let me know. 306 891 5649. Okay. Did it come to you?
Yeah, it came. Thank you so much.
Awesome.
Yeah. So I'll be sharing you the details and all, and
Sure.
then we can go ahead with that.
No worries. Yeah, I'm here to support you. All right.
Thank you, Dr. Brony. Yeah.
Good.
Take care.
No,
I'll
Doc,
sign
that's
off.
fine.
Bye-bye.
Okay.
Bye.
Good. Bye. Dr. Sabine, what have you learned
Yes,
so
sir.
far? What have you learned so far?
Hello, Dr. Bruni. How are you?
Hello, I'm fine, Dr. Sabine. How are you?
I'm good, sir. Hello,
Good.
everyone. Yeah. Sir, I want to let you know, other people know, other doctors know that I'm a med cognito student. I'm good.
Oh, okay.
I'm already a med cognito student, and
Okay.
I'm so fortunate that I got a chance to enroll into the med cognito, and
Good.
Dr. Bruni is the best teacher I ever had.
Oh my goodness.
The concepts you made, sir, so much clear, and I really enjoy the classes, and I really don't want to miss that classes that you teach.
Yeah.
And we have very good instructors as well.
Yes. Because all of them are, practicing physicians in the system, right?
Yes.
U of T, UBC, University of Saskatchewan. So it's good. Like, all the teachers are very, very good. And Dr. Sabine, I really like your spirit, right? You come in, you participate, you read concepts.
Yes.
No one comes to class who doesn't know Dr. Sabine, right?
Thank you, sir.
Sure.
It's because of you, sir, because the QE1 is the very difficult exam. But you make things so simple, and the focus, we have to study the focus on things here.
Yeah. That's good. So I'm very glad. And Dr. Sabine, you have my phone number. So just let's keep talking, right?
Yes, sir.
Yeah. Okay. Any other person who wants to join us? If not, Dr. Sabine, there's a class tonight, so get some rest and join the class, and let's move on. All right. Okay, doctors, thank you very much for spending your afternoon with me. It's always a pleasure. Let's keep impacting lives. And somebody said something here. Dr. JJ says, Dr. Bruni, since you attended the IMG Symposium in Ontario, please give us key points for easy approach residency programs. Well, I didn't attend that IMG Symposium. I just went to work in Ontario. I didn't attend the IMG Symposium. Yeah, but I think with easy points to approach the residency program, number one is make sure that you've aced your QE1 very well. Make sure you've aced your NACOSKI very well. Make sure you have good reference letters. Make sure you have good CV, and we help with all that, like especially the CV part. For the reference letters, you need to get it from doctors you've worked with, right? But for the CV and interview prep, we are here to support you. So doctors, don't hesitate to reach out. But those are the main things. You need to have a very good story. You need to have a very good background. You need to understand and make sure that you don't also miss the timelines as well. And know the program you want to go into. And then just make sure that you fit the criteria. And when you come to us at MedCognito as well, we have a special doctor who deals with all these and who reviews them as well. We are here to guide you. No worries. So yeah, doctors, it's been awesome. Let's continue studying. And please remember, there's a class tonight. Emergency medicine with Dr. Edwin, right? So see you. Enjoy your day. And bye-bye. Bye-bye. Oh, Dr. Isaac. Okay. Sorry. Dr. Isaac. Yeah.
Hello, sir. How are you? Hope you
I'm
are
fine,
fine and
Dr. Isaac.
doing. Yeah, the class was really good. I enjoy a lot. So
Yes.
I joined from my other ID, not from my other from my own Facebook name.
Oh,
So I
okay.
really enjoy it, and I really appreciate, sir, the
Sure.
way you are teaching, the way you are helping us, and it's really
Yeah.
I really appreciate it, sir. I
Yeah.
enjoy a lot.
Sure. And Dr. Isaac, you have my phone number. You know you're always in touch with me, right? So
Yes, sir. Yes,
if
sir.
there's any concern, just reach out and I'll deal with it for you. All right?
Thank you,
Yeah.
sir.
Let's keep acing the
Good day.
exam. Let's keep preparing. All the best. Dr. Isaac,
Thank
it was
you.
great seeing you again. Please don't forget to text me. Worry me. Okay? Worry me. Okay. All right.
Yes, sir.
Bye-bye. Bye-bye.
Thank
Bye-bye.
you. Have a
Okay.
good time. Bye bye.